I'm going to be talking about the time of initiation of basically renal replacement therapy in AKI. It's on the journal from 2020. But I think it's a multinational journal. So start from the start. So AKI, we see it everywhere, we see it all the time. And it looks like we always start at random times as well. And that's why this came about. Obviously, the thing that people think is, oh, if we start it early, will it help? Instead of starting it late, sometimes we wait around, hoping that their kidneys work, and then they fall off sometimes. But hence why this is done. So there's associated risk of death, major complications, and it uses a lot of resources. You can tell from our dialysis machines. It keeps running, and uses a lot of water. You need all the pumps and everything happening. So it does use a lot, and as well as skill mix as well, nurses. And it's used frequently to treat obviously AKI with other things going on. So acidosis, hyperkalemia, uremia, and fluid balances. And its benefit is a bit unclear on like pure AKI. So main questions that they're trying to ask is, why not start beforehand, right? Why not prevent the major complications from happening? Hence why they've done the randomized trial to compare early versus late, or not late, but like delayed, or like when you would normally start your renal replacement therapy in critical ill patients. And the hypothesis is that it will result in lower risk of death, because it will prevent major complications, as we would like to think. So essentially, so it's a multinational randomized controlled trial. So it's across 168 hospitals over 15 countries. And you can imagine the what annoying organization it would be. Lots of funding, lots of people involved to implement it, analyze data, approved at every single place as well. What a nightmare. And then you have to write up consent for each patient, pertaining to local guidelines as well. And then they looked at the primary outcome at different targets, obviously to not like make sure more people get killed because they didn't start treatment early enough. So at 25%, 50%, and 75%. So selection-wise, so they looked at patients that are above 18 years old in ICU with some form of AKI. So it went by the KDIGO classification. Just to remind you of it, so essentially it's for stage 2 to 3 for severe AKI. That's when you double your serum creatinine levels from baseline, or if your creatinine is more than, I think from us it would be 354 micromoles per liter, which is quite a lot already. And it's or an increase in more than 27 micromoles per liter from their baseline, or a urine output of less than 6 mils per kilo of body weight. And they did, it has to be excluding any circumstance that would otherwise give them reason to start RRT immediately on admission, versus delaying it. Because this, I think, usually for these selection criteria, it's like you can't wait a little bit first. They're not like imminently requiring RRT as the main reason for admission into ICU. So they were evaluated using these SAPS scores, essentially as well. Essentially, high score, bad, high risk of death, and then there's also the SOFA score, which I think we were supposed to use it for I think sepsis at some point, and somehow went away, and no one really used it that much anymore, other than in papers. So yeah. So this is all the boring bits, but essentially they randomized it. They chose between they call it accelerated versus standard strategy versus like the early versus the late. And they had risk stratification using some website, and then they start your renal replacement therapy in your accelerated group within 12 hours after the patients meet the eligibility criteria versus the normal or the standard group. So then for those ones, they kind of discouraged from like initiating early until something like one of the major complications essentially occurs. So like potassium more than 6, pH less than 7.2, bicarb less than 12, evidence of severe respiratory failure, and involved ratio between PaO2 and FiO2, and then clinical perception of volume overload, persistent AKI more than 72 hours after randomization. And so in those situations, then they'll start RRT with their severe AKI. And then protocols were provided to the people in the trials and to deliver RRT with recognized guidelines, and then they would discontinue RRT at the time of recovery of their kidney, or if they died. So primary outcome is death from any cause at 90 days after randomization. Secondary outcomes is so dependence on RRT, so like they're like on it for longer or than 90 days essentially, or death, or some form of major kidney problems, a major adverse event due to their kidney injury. So death, dependence on the RRT, or sustained reduction in kidney function, say less than 75% of their baseline. And then there are certain outcomes pertaining to the secondary outcomes. They kind of took info of just to look at, and they'll summarize later on, because it's like useful, interesting information probably. So they look at death in ICU at 28 days, so during hospitalization, number of days free of your renal replacement therapy at 90 days for those that cured from it. The number of ventilator-free days at 28, number of vasopressor-free days at 28 days, length of hospitalization-free days at 9 days, and any health-related quality of life. Basically, they assess that with the EQ scores. So adverse events relating to RT and vascular access were reported through 14 days among all the patients who have undergone randomization and remained in the ICU. And all serious events were reviewed within 48 hours of notification. So they call it the modified intention to treat principle. Essentially, is the accelerated versus delayed strategy. That's all they mean. I don't know where they get 40% from, but they assume a 90-day mortality of 40% in the standard strategy group. It's probably based on previous papers and stuff and other RCTs. That's probably a 40% mortality in general. People will start on RT and ICU. And so they enrolled about so from the analysis, they think that they need about 2,800 something patients, and however, to account for attrition for like people like falling off, or withdrawing consent, or people not getting followed up, they enrolled about 3,000 patients to make up for that. And this is so that there's enough power in the trial. For primary outcomes, they used various tests. So they used the chi-square tests, and they also looked at various ways to analyze. They use a graph, the usual Kaplan-Meier time to event analysis. So from the time they start from consenting till from randomization till they either died or to 90 days or to when they cured. And then otherwise they use other pre-specified subgroup analysis just to see any relationship with primary outcome. and then the secondary outcomes, as mentioned before, secondary outcomes are your dependence on RT, death, and any major kidney, a major event related to your kidney injury. They use basically the same thing. They use chi-square test again. They also use t-test to compare your creatine levels in GFR. They summarize a lot of the details, as mentioned from the pre-specified secondary outcomes. So like all your ventilation, use of drug, psychoactive drugs, length of stay, etc. So they can't summarize the median and interquartile ranges. And then yeah, they did a bit of linear regression data as well. And everything that they've done, any calculation, are all within the 95% confidence interval. So results. So as mentioned, so about 3,000 patients were randomized, 3,019. And then there are 2,927 that are included. And then, so half of it's in the accelerated group, half of it in the standard group. And then almost as you expect in the accelerated group, most of them would be on RT. If not, it should be all of them, but maybe some of them didn't read it in the end. But so that's why most of them, 96% were included, whereas on the other side, on the delayed side, only 61% were included, because they started RT. At 90 days, so death occurred in close to 40%. And in both groups, basically, it looks pretty much the same numbers essentially, and this is within 95% confidence interval. And then among the survivors at 90 days, the continued dependence on the RT is higher in the side of the accelerated group versus the side of the delayed group, essentially. So 10% versus 6%. And any adverse events that occurred more often than the ones that you actually started earlier, because they're probably on renal replacement therapy, which has its own problems, and hence why they probably had more adverse events compared to the side that only 60% actually had RT. And then there's a lot of numbers. There's a lot of numbers that are too small to read, and they all basically say that they are almost the same on both sides. That's what I can summarize. Is all the numbers are almost the same, but they are very small numbers. I cannot read them. I will not read them. In the entire population, so the whole detail or the whole slide before. So CKD was present in about 1,284 patients prior. 900 patients have been admitted, went to surgery. About half of the patients had sepsis and the mean scores. So high scores worse, basically. So so your SEP scores about 11 on the other side. But if we go back, essentially, where is it? Let's see here. Oh, here. So yeah, basically the SAP score is here, and your SOFA score is here. It's like it's almost the same. It's like 58.1 on one side, 59.4 on the other, 11.6 on one side, 11.8 on the other. Essentially, it's just no difference. So initiation of your RT. So for the accelerated group, essentially they started within median-wise within 6 hours of admission, of randomization, admission here. The interquartile range is between 4 hours and 8 hours after determining their full eligibility. And then the standard strategy is a very wide range between 20 hours and 19 hours and 71.8 hours. So that's about almost close to a week, isn't it? Oh, midweek. And so yeah, and as mentioned, they looked at various things, and essentially the SOFA score, creatine level, blood urine nitrogen level, and positive fluid balance were higher among the standard strategy versus the accelerated strategy, which makes sense because they've been ICU for longer. So they'll obviously get worse. And they waited until something gets worse first before actually starting RT. So that's why these things will be high anyway. But, yeah. So primary outcome, death at 90 days, or mortality at 90 days. As mentioned earlier on, it's about 40% in the SRA strategy group versus the 43.7. So it's literally almost the same. And that's the same even if they did like their analysis. And then for their secondary outcome, for the patients who were alive at 90 days, that continued to have some form of dependence on the RT wasn't that high in the delayed strategy, as mentioned earlier on, versus the accelerated strategy. It's quite weird. I don't understand why they would be more dependent on RT if they were started earlier, but it seems to be what they found. And otherwise, yeah, there's no real big difference between the two sides, basically, on like, the composite, so like between death and dependence on RT at the same time, or any sort of major kidney events. So yeah. Secondary outcomes wise, so in each group, so there were the patient had a similar number of days free of the RT and 90 days. They said that the accelerated group had had a fewer that were free of RT, but they're pretty much almost the same anyway. So it doesn't really matter. And then patients on the accelerated group had shorter ICU stay, but there was no evidence of large differences between ventilator 3 days or vasoactive 3 days or ICU 3 days at 28 days. And that's a lot of numbers again, but essentially similar to the ones before, which is the numbers are almost the same, other than the differences mentioned earlier. So a bit, we mentioned was higher in the accelerated group versus the standard group. But everything else looks about the same. So, and it's the same thing again. And yeah. And that's their quality of life, which is about the same. So quality of life is just bad regardless, both sides. So subgroup analysis. So that's what we mentioned earlier on about the pre-specified numbers or the pre-specified data they were looking at, like length of stay, quality of life, SAP scores, SOFA scores. So there was no evidence of big differences between the two groups essentially. They look at the heterogeneity. Essentially, it's like anything that could affect the actual data, like any biases or anything. And there's not a lot of difference in biases either on both sides. So this is your Kaplan-Meier score. It's basically comparing the survival between the two groups, which looks like the same line basically because it's the same. And then all I know from this graph is basically if anything crosses the line, it's good. It's that there's no difference between the two sides. And basically, there's no difference between the two sides on any of the data they looked at on the subgroup analysis. So like all your gender, estimated GFRs, aptitudes, sepsis. There's no real difference between the two sides regardless. So yeah, conclusion. As you guessed it, there's no difference between starting early versus starting later in terms of like overall primary outcome, which is the 90-day mortality. And it looks like most of the other information that I looked at as well, the secondary outcomes and the subgroup analysis, everything was about the same as well. That's really not much of a difference. You probably just use more resources at that point if you start them early. That's probably maybe the only thing. There were 2 other multi-center trials that are ongoing during this time, and they also did not show any lower risk of death with starting early versus starting later. They also said there's a greater percentage of survivors who received accelerated strategy were dependent on RT, as mentioned earlier. It was double the number that were that started later, the delay strategy. And they suggest that it's because it could be they're exposed to RT more. Well, more people are exposed to RT, and hence their baseline risk is modified. And then so there's other things like iatrogenic factors, hypertension, etc., and just things related to your use of RT. There's a thing that it could be because of just the repair of the kidneys are not, and the actual endogenous repair of the kidney function is just not returning, probably because it's impaired repair. And that's it. Summary, doesn't matter. Started when you think you need it. There's no effect. Yeah.
Slightly different. Probably the takeaway from this study was the primary outcomes don't matter.
Yeah.
Starting it early is going to delay your recovery.
Yeah. Exactly.
So this signal came up in multiple trials now.
Yes. Yeah. Yeah.
Probably the takeaway.
They should have said that in the conclusion.
Yeah.
And there is a recent trial that 2021. They compared delayed versus very delayed start.
Oh, very delayed.
So they waited for almost 3 days.
Oh, okay.
Average these patients had a UA of 50.
Yeah.
The mortality was much higher. You could delay so much compared to a delayed strategy.
What I'm really interested in is actually the delayed group. How many of them actually get away without being forced at all?
In the very delayed group, like 20% got away with it, but 80% hated it.
And then what happens to 20% that got away with it?
Well, I haven't looked into that.
But as in like these sort of like timing studies, usually, I mean, the ones that actually end up like 40% of them died. Actually, that's really shit. Imagine if you started someone on dialysis and then you told them, by the way, now that you're on dialysis, you've got 40% dying because filtration is really shit.
Yeah.
60% have sepsis with multiple organ failure. 60% have sepsis groups.
I mean, from what I saw here, like they said, like 60%. So not 60%. Yeah, 60% actually met the criteria on the delayed group. So it's like they not that they've met the criteria, but like they were actually started on RT. This one, yeah. So out of 14,600 patients, then RT only started in 900 of them. So they did avoid it.
40% got away.
Yeah, 40% did get away. So that's what I mean. You can save some cost by not starting dialysis on 40% of your patients and still get the same outcome anyway.
Yeah.
But yeah, I don't know. But then it sounds like people are then made dependent on it instead, or at least more people are made dependent on RT than they normally would be. They could have gone away with not ever having met a filter at all. So.
Cardiac centers was still different.
Yeah. I think most people, no one actually starts it early unless like clearly indicated anyway. So, which is excluded obviously in this trial. Like people were coming in who already they need it, right? Yeah. Yeah. So these are patients who then develop AKI later on in ICU, and then So. Dun, dun, dun. It's kind of like Darren Dunkley.
Huh?
Darren Dunkley. I'm trying to think. Wait, was he starting?
No.
Oh no,
He got away.
He got away.
This is
He was one that got away.
Yeah. He might have been started.
He may or may not be allowed in that day.
Yeah. If he had those, he would definitely not get off it.
Yeah.
So. So I think a lot of people opt to just wait a bit longer and see whether the body fixes something.
To say the 20% that got away. Or deteriorated so badly that
They did that.
filter.
Yeah, it's like, oh. Save some money.
No, but I agree with that. There are loads of. I mean, this is probably the biggest one and most well run of the. When shall we start the filter type studies? And always the answer is the same, which is it doesn't make a
Yeah, it does. Yeah. Yeah.
Which is why mosaic will be interesting when the answer is bicarb versus filter. When it's just like, oh, filter later versus filter earlier.
Yeah.
Actually, you need to compare filter versus filter.
But versus a different treatment.
Exactly.
Yeah. At this point, because there's so many treatments, so many done already. Filter versus filter. It's like it's the same.
Exactly. It's like filter versus filter. In pancreatitis, filter versus filter. In cardiac patients, filter versus filter. It's all the same. Exactly. It's all the same.
Yeah, I'm going to talk about fluids. I've not met you. My name's Jo. I'm one of the registrars. So like I said, the aim really is to sort of like uncover what I've spent years and years and years understanding how we give or take away fluids on ITU. So why, how, why not we do fluids, what fluids we use, when we do it, how much, and what happens when we give too much. So that's basically like a skirt around everything. This is going to be interactive. Please tell me why we give fluids. And I've forgotten what's under each of the slabs. So I'm going to open my cheat sheet and you are going to shout at me why we give fluids.
Hemorrhage.
Oh.
What was that, sorry?
Resuscitation.
Resuscitation, I think that is. Number 3, improve cardiac output.
Sepsis.
Improve cardiac output.
Dehydrated.
Still
Say that again?
the same, I would say, yeah. Electrolytes.
Mate, yay! Thank you. Thank God. One more. I think I heard someone say dehydration.
Yeah.
That'll do. Replace losses. This goes on, by the way.
Oh.
So, how do we give fluids?
Oral.
A, oral. That comes under enteral. Oh, okay.
Okay, well, I guess. NG.
NG, enteral. Where's that?
Oh, yeah.
And finally,
Subjects.
this is actually you. We don't do that.
Oral. That's
Enteral. It's ITU, therefore.
Oh.
Well, this is.
Wait,
This is
can you
a bit-
filter?
Yay!
And prevent loss.
So extracorporeal circuits, and that includes filter, it includes ECMO, it includes bypass. Which I know technically is intravenous, but you're not just like chucking things in,
Yeah.
right? You're like manipulating what you're giving. I think there's one more. So why not? What are the harms of fluids? Everything we do on ITU, there is a harm. So what is the harm?
Failing heart.
Overload. I heard heart. I'm going to come that onto overload.
Oh, anything else. Cheated. Electrolytes.
Electrolytes.
Yay.
Because they can drink.
Okay, fine. So patient self-dependency.
Rehab.
Yeah, I like that.
Rehab.
No. 2 more. It's sort of associated with overload.
But they're already bleeding to give blood.
I mean, that's just fluid.
That is
Edema. One more, which is a bit more obscure. And if you read about fluids, you'll see it's one of the consequences. Vexus renal capsules. That's not helpful. Say that again, Atla.
Beans condition.
Yay! I'm easily pleased. Sorry, there is one
Isn't it
more.
overload?
Sorry?
Isn't it overload?
One of the consequences of overload, and we'll come into that. So, what fluids can we give?
Normal saline. I know you
Oh.
What is normal saline?
Is that philosophical question?
What is normal?
There's only 4 tabs, come on. Normal,
Harmons, plasmolite, dextrose.
they are.
Albumin.
Crystalloids.
Go for that.
Oh,
Yay! 2 more. Blood products.
Wait, that's cool.
We actually give a lot of it here.
Albumin.
What is
Colloids.
Jello.
That's the story.
We give loads of it. Oh, nutrition.
Oh.
Yay! Now I need to talk.
Oh.
So, one of my questions is what fluid. So we talked about why we do it and all of the rest of the stuff. So how do we choose the fluid? I have spent 10 years figuring this out and I still don't know the answer. But these are the 5 headings of the things that I think what matters, what we give to fluids. So what electrolytes are in it, what does it do to your acid base, the tonicity of the fluid, so they'll still understand it. Colloid pressure and pharmacokinetics. So what does the fluid do to you once it gets in you, other than slosh around? So number one, electrolytes, death by table. Anyone who hasn't done the exam, here's a table. Anyone who's done the exam, please switch off. So down the left-hand side, we have different types of fluids, and in the middle are numbers that I have lifted out of my textbook. Here are some numbers that I would like to highlight. So when we're choosing between 0.9% saline and plasma-like Hartmann's, I would like to highlight that 0.9% saline has a lot of chloride. Our usual body concentration of chloride is about 110. So when you're giving 0.9% saline, you are giving 154 millimoles per litre of chloride, which is more chloride than what is in our plasma. And this has been fixed in plasma-like and Hartmann's. However, it has been replaced by what has been bolded, which is acetate and lactate. The reason we need so much chloride in 0.9% saline is because sodium is positive and chloride is negative. So if you get rid of some negative stuff, you need to replace it with other negative stuff. So whoever manufactured plasma-like and Hartmann's thought, I will stick some other negative stuff in instead. So that's acetate and lactate. Now that comes under the bicarb column because if your body works and your liver works, they get metabolized to bicarb, and it's all very clever. So when someone comes and says, oh, you shouldn't be giving lactate to your patient, if their body is working, they will metabolize it to bicarb. It's okay, don't worry about it. What else did I want to highlight? 8.4% bicarb is wonderful, but it is not harmless. It is very, very, very hypertonic. I'm sorry I'm teaching grandmother to suck eggs. This was all like sort of like revision for me, and I was like, wow, that stuff is really toxic. So 8.4% bicarb has a huge, huge, huge sodium load. It is 1,000 millimoles per litre, which is like 9 times more hypertonic than plasma. So when you're giving it, just bear in mind that even though you're only giving a little 100 ml bottle of 8.4 bicarb, you're actually going to cause fluid shifts that are actually giving a lot more fluid than that. Which is why one of the exclusion criteria for Mosaic is the inability to tolerate a fluid load, because the bicarb protocol in Mosaic is to give 8.4% bicarb. And even though it's in 100 ml, you're actually going to cause such massive fluid shifts that you're actually giving your patient a massive fluid load. So bear that in mind when you're like chucking in 8.4% bicarb to your patient who's really acidotic, thinking you're going to save them. Because the next thing you know, A, they've got loads of bicarb which they need to breathe away, and then their lungs are full of edema. I almost did that to a patient once. I was like, oh, let's chuck it all in. And then Dr. Hedge was like, don't, Joe, do you remember X, Y, Z physiological principles? I was like, oh, yeah, I'll calm down a bit. HAS at the bottom. This is also education for me. 5% human albumin, 20% human albumin. So 5% human albumin is pretty uniformly made, it seems, and it all has sort of like 130 millimoles per litre of sodium, which is sort of like sounds fairly benign. However, 20% has anything, depending on which country it's from, apparently, 63 to 120 millimoles per litre of sodium. So actually you could be giving, even though it's very like colloid concentrated, you might actually be giving quite a hypotonic fluid to the patient. So just bear that in mind. But if they need HAS, if they need albumin, they need albumin. But that's also another topic of contention. So there you go, enough of that table. Any other questions about electrolytes and that why we choose fluids?
Yeah, I have.
Please.
So normally, as you mentioned, body is working well, then lactate gets converted to bicarb. Does acetate, so in CLD patient, liver disease patient, we tend to avoid bringing the lactate for the same reason. Does acetate goes into bicarb as well in the liver?
I'm going to say the same cycle, so probably, but I'm not sure.
Yeah.
Corey cycle is a cycle.
In the liver. In the liver.
So acetate gets in the liver.
Yeah.
Ultimately,
Yes,
same
India.
arrows, circles,
Just thinking that there is no other exclusion apart from CLD. This is why I asked.
or a cubic.
Yes. Thank you.
Acid base. Oh no, where's my acid?
Electrolytes.
Oh, I was still on the electrolyte. I thought I finished with the electrolyte. I'm sorry. So this is targeted at Kim, who is going to have a surgical job and is going to go on night shifts and is going to say, please prescribe maintenance fluids for these 17 post-surgical patients. These are your daily maintenance requirements. These have been simplified so that my FRCA brain could remember them, where sodium and potassium are both apparently 1 millimole per kg per day. Actually, sodium you can get away with a bit more, potassium you can get away with a bit less. But FRCA brain can only remember one number, so I went for one in between, which is 1 millimole per kg per day. But anyway, these are your requirements. And the point that I've put it there is when I was an F1, I copied the person above me, which is 3 litres of normal saline, 8 hourly. And now I know that you're massively overloading your patients. I mean, I'm not going to do loads of maths, but I did work it out when I made this presentation that for a 70 kilo person, assuming that they're just nil by mouth and they're not septic and their endothelium works and all of their kidneys are working perfectly, it's under here. But 1 litre of dexaline with some potassium and 1 litre of Hartmann's over 24 hours is more than enough. So when you're prescribing your maintenance fluids for your post-surgical patients, just bear in mind that don't copy the person above who prescribes 3 litres of normal saline. I don't know, do you all still do that? They did when I was an F1.
Yeah, I'm being this.
Sorry?
I've done that many times.
2 salty, 1 sweet. That used to be the whole.
Oh, and then it got a bit progressive, and then dexaline got in place, and then
people got hypotonic and crazy.
it was just so much. And then at some point in history, I went to this weird quality improvement conference, and there was this person somewhere in the north who did this quality improvement project who basically educated every single doctor in the hospital to prescribe actual maintenance fluids, and they saved thousands of pounds in just not prescribing so much fluids. Patient outcome,
same.
Exactly, probably the same. But they just saved thousands of pounds in Hartmann's because everyone just got less fluids. So there you go. That's my little sort of persuasion to not prescribe 3 litres of normal saline a day. But of course, that's assuming your patient has non-leaky endothelium and everything works and they're just nil by mouth and you need to give them maintenance fluids. However, on ITU, our patients are never actually like that, which is probably why we use so little dexaline, for which reasons I will come on to later. I think I finished talking about electrolytes now. Acid-base consequences of the fluid that we give. There is a slide dedicated to chloride. This is something else that I've spent years and years and years trying to figure out. Why do we hate chloride so much, and why does chloride, which is just the negative ion, cause acidosis? Please correct me if my understanding is simplistic. It's actually simply that humans are not batteries. So if you give someone loads and loads of chloride, then you can't just make them negative. They have to their plasma has to become neutral somewhere. So they just chuck all the bicarb intracellularly, and therefore their plasma can no longer buffer acids, so they're acidotic. Does that make sense? That's basically, I don't know why it took me so many years to understand that. I'm just simple. And this diagram basically this is more about bicarb and why bicarb is so important. And then they've just put a little thing here, chloride. And it's oh, if chloride goes into the cells, the bicarb comes out. No. Chloride into plasma, bicarb into cells, and then your plasma becomes acidotic. So that's a chloride shift because humans are not batteries. I don't know why I put that there. I may have been sleep deprived when I made this. That's what I've just said. So hypochloremic acidosis, or what you said, you use a
HMA.
I don't remember what that stands for.
It's hypochloremic metabolic acidosis. Still the same.
It's the same thing. I've tried reading a few articles to say, well, does it actually matter? Because people get very, very heated about normal saline versus Hartmann's, and is hypochloremic acidosis actually bad for you? There's some evidence out there that if you give renal failure patients lots of normal saline, they get more rates of AKI. But other than that, mortality, length of stay, all seem to be the same. So actually, you can give your patient normal saline if you want, according to all of these sort of systemic meta-analyses. And a lot of the papers actually argue is why are you getting stressed about acidosis? It's not the acidosis that kills you, it's the condition of the acidosis that kills you. So actually, if you're giving some chloride and the person becomes acidotic, that's not actually pathology, that's just a bit of iatrogenic harm, if that makes sense. Someone becoming acidotic because you've given them lots of normal saline is not the same as someone becoming acidotic because they're septic or whatever. So stop stressing about it is what that line means. And like I've said already, lactate, acetate, gluconate, they're just alternatives to chloride, so that Baxter and all those fluid producers can say, but I've given you some fluids that have less chloride. That's it about acid base.
One renal transplant patient, they keep on asking to give normal saline for fluid.
Probably because of that little bit of potassium, and transplant surgeons hate potassium, and they don't understand.
Animals of potassium.
Exactly, and I bring you back to it.
You'll be hyperkalemic.
And they stress about it, but seriously, because they're surgeons. I also read some articles, I mean, we come across some of this. Surgeons' view on fluids is very different to anaesthetists and intensivists' view on fluids. And I will come on to that when we come to talk about fluid
Just to
overload.
add on, because renal patients mostly are on bicarb anyway. So even if you give them saline, they will compensate.
They will compensate or they won't compensate?
They will, because they have bicarb.
Oral bicarb.
So they want us to give normal saline because they can get away with it.
Yeah.
Or why don't we just give less?
Avoiding
bicarb?
avoiding other things, but it's just small.
I know.
They also think that more fluid equals more blood pressure, so.
Yeah.
That's all I'm going to say about that one. All right, where are we up to? Right, tonicity. So where does fluid go? And if anyone has ever done primary FRCA practice with me, you'll know that this is one of my favourite questions, even though I don't really understand it either. So if you're giving someone a litre of fluid, where does that litre of fluid actually go? And I've sort of like got two principles depending on water compartments about where the fluid actually goes. Principle number one is that your endothelium of your blood vessels are impermeable to proteins. So if you give someone with a whack load of protein, then the water is trapped into wherever you've given those proteins to, which is why, in theory, the theory is that if we give colloids, because you've now trapped your water in your blood vessels with your protein has, then you get intravascular expansion, and therefore you improve cardiac output, all random stuff. That's from my textbook to explain the same thing. I'm not going to go into it. Protein in blood vessels, water follows protein because endothelium is impermeable to proteins. Does that make sense? Simple. Or does it? And I've put at the bottom here, or does it? Because, because now these are just theories, and please add to them. If you fluid overload someone, you're just going to stretch that endothelium so wide that you've got physical gaps for your colloid to go through, and therefore water will follow those gaps. Therefore, it does not work if you just give someone loads and loads of albumin and they've got leaky endothelium. Sepsis, any inflammatory response, your endothelium is leaky regardless of what you give. So actually, why give colloid? Can I think of anything else? Any flaws to the argument? Any other flaws? Basically. So colloids are not the answer to everything. So principle number one, endothelium is impermeable to proteins, therefore if you give protein, water stays in blood vessels. Principle number two, cell membranes are impermeable to sodium. Therefore, if you give a load of sodium, you will keep water outside of the cells. Hence, if you give isotonic or hypertonic saline, so fluids such as plasma like Hartmann's, anything with a reasonable amount of sodium, the idea is that the water won't stay in the intravascular space because it can just leak, like freely leak through the endothelium. However, it will stay outside the cells, and therefore you get less intracellular edema. So the reason that is important is because all our encephalopathic patients, particularly, so Dan Dunkley, when he first came in, he had a sodium of 160, which you can sort of like get very stressy over it, but actually the benefit of him having a plasma sort of like serum concentration of 160 is that actually therefore you're pumping water out of his brain cells. Therefore, actually trying to lower the sodium too much will actually risk water going into his cells and him getting cerebral edema. And actually, if you talk to a liver unit about a patient who has encephalopathy, usually their first bit of advice is give hypertonic saline, aim for a plasma sodium of 150 to 160 because you want to keep water out of the cells in the interstitial space. Does that make sense? And that is why we tend to give iso or hypertonic fluids on ITU because we have leaky cells and we don't like cells to swell up, which is why if you give saline on here for maintenance fluids, people go, why do you? Whereas on a medical ward where you haven't got leaky cell membranes, it's okay to give them some saline because otherwise they get sodium overloaded instead. Is that everything I have to say about tonicity? and colloid pressure. Pharmacokinetics. So for pharmacokinetics, when you're chucking a litre of something into patients, what happens to the stuff that you're chucking? Talked about electrolytes. Acetate and lactate gets turned into bicarbonate. Like you said, in liver patients, not just the chronic ones, the acute ones as well. They might not actually turn it over, and they might not actually generate bicarbonate, which is why they get more acidotic. Same thing actually when we filter patients using citrate on here. We're giving the patient a workload of citrate. Usually patients can metabolize it, and that's why the acidosis protocol works. But actually, if you've got a liver failure patient and you've got some sort of like weird like acidosis protocol that delivers more citrate to the patient, they actually get more acidotic. The liver patients get more acidotic because actually they're just building and building citrate. Glucose metabolizes and turns into free water, and albumin, there's a risk of hypersensitivity. That's all I can think of to say for that. So August 2023, the European Society of ICM actually published this as like, it's a big document. It's sort of like a part 1 out of 3 series about what fluids to use in different situations, sort of like tying in together everything that I've talked about above. And basically, this is a summary of like a 17-page long piece of paper about like all of their analysis of all the evidence. In general, balanced crystalloids, basically HAS is good for almost nothing apart from cirrhosis. And that's what it says underneath this bar here. So basically this sort of guideline goes through like loads of comparisons and loads of trials comparing this to this, this to this, this to this. And in general, in most situations, balanced crystalloids, i.e. plasma like Hartmann, is better than both normal saline and HAS for most situations. However, if you read into it a little bit more, number 1, the quality of evidence is low. And number 2, the differences are marginal. So just grab whatever is off the shelf and give it. But don't give the HAS here because HAS is expensive. I think in Australia, HAS is actually like cheaper. So give HAS if you're in Australia. Traumatic brain injury, isotonic saline is better than everything else. Definitely better than HAS. There's a safe trial, which Nisha will one day know about it when she's arriving for her exams. I've forgotten, but basically they gave albumin to a load of kids in Africa with traumatic brain injury and they all died. So don't do that. Something about them being malnourished and being unable to cope with the protein load. But anyway, so in traumatic brain injury, exactly what I was just saying about encephalopathy and trying to keep water out of cells. So ironically, in traumatic brain injury, if you give normal saline, the outcomes are marginally better than giving plasmolite, because plasmolite is just marginally hypotonic compared to cells. So if you give isotonic saline, it just keeps the brain a little bit drier. Bleeding, give balanced crystalloids more than HAS, but obviously give blood if you need to. And cirrhosis, it says under here, give HAS more than crystalloids.
So give mannitol. Brain.
I'm glad so mannitol, so hypertonic saline is now more in vogue than mannitol.
Oh.
So mannitol being a plasma expander because it's like a colloid. But actually, what some are thinking is that in traumatic brain injury, the blood-brain barrier itself is disrupted.
Fine. Okay.
So actually, if you give mannitol,
yes.
so water just goes out.
Yeah.
Exactly. Whereas if you give hypertonic, and like mannitol itself is like toxic to the blood-brain barrier, and therefore just like causes water to seep everywhere. Whereas if you give hypertonic saline, exactly. When is fluid too much fluid? So this is a diagram from a moderately good article. I'm going to say moderately good article called Everything You Need to Know About Resuscitation. I say it's moderately good because it was a little bit too complicated for me. So there's this diagram and it basically goes through all the harms of if you have too much fluid, and it says don't call it fluid overload, call it fluid accumulation. I was like, you call it whatever you want. Like it was just a bit pedantic about things like that. So if someone has too much fluid, and if you have fluid everywhere, if you have fluid sort of like peripheral edema, then actually what's happening inside the organs, your kidney is a bit boggy, everything's a bit leaky, your arms and legs are heavy and you can't move, and all the stuff that is on this diagram. And then there's another diagram which basically like overcomplicates, which basically says if you've got an acutely unwell patient, there is a pattern that we follow, which is where you give them a load of fluid and then we offload them at the end. And then it's made it horrendously complicated using this diagram. But it's here and it's a diagram and it's better than my text. But they call it de-resuscitation.
So do they think that's a good thing, Joe, when we do that?
Yes.
Okay.
So it is a good thing because principally what we're giving, like we fluid resuscitate because of the pathology, and we'll come on to that, what the pathologies are. And then that water basically sits in the wrong places and causes the harms which are in this diagram. And we basically need to get rid of the fluid. And a lot of it is iatrogenic harm, because we've initially given the fluid to expand the vascular space. It sits in the lungs, it sits everywhere, it sits in the arms and legs and stops them moving, and we need to get rid of it. So how to do it: reduce fluid load, so stop the maintenance fluids if they don't need it. Fluid restriction, so who comes to mind? He gets about 1 litre a day in antibiotics. Linezolid is like a 400 ml vial, and he's got like 2 doses of that. Vancomycin, I think, comes in like 200, especially if you've only got a peripheral line. Omeprazole is 100 mils, paracetamol is 100 mils, which is why I spend a lot of time crossing them off. And fluid removal. So this article says what ways of doing it, and it says if you've got reasonable kidneys and diuretics is better than filtration, because filtration is expensive and harmful. But if it doesn't work, then yes, you just have to do renal replacement therapy to get rid of the fluid. So we've sort of like touched on, is it a good thing? When do we do it? So now that I've talked about what do we have at our disposal, which is lots of different types of fluids and ways of getting rid of the fluid, then how do we decide when we give the fluid or take the fluid away, and how much? Anyone who's got exams coming up, I would like to take a history, I would like to examine a patient and do some investigations. I'm going to start with the history. I'm still start. Can you tell? So, history from the patient to decide to give fluid, to take fluid away. So number one, I mean, this is kind of like cheeky, but in the history lab, what is your diagnosis? What is the pathology that you're dealing with? Because that determines how much fluid you're going to give. What is the source and what is the type of fluid loss, and what is their ability to tolerate the fluid load? So your classical sort of like dichotomy is if you've got a 20-year-old with DKA, it's okay, you can just chuck loads and loads of fluid at them. But if you've got an 80-year-old with DKA and you give them like 1 litre of normal saline and then they stop breathing. So that's annoying. So the diagnosis, and I've just got a list here of sort of like common-ish pathologies which are associated with chucking loads of fluid at them. So when you are chucking loads of fluids at these patients, you need to think about, why am I chucking fluid at them? And like at what point is actually too much? So sepsis is the common one, where the pathology of fluid deficit is endothelial leak and vasoplegia. So like actually the patient is third spacing themselves into the interstitial fluid, cellular edema. And actually all you're trying to do when you're giving fluid is to maintain cardiac output. And you just have to like take the hit from that, which is more in like interstitial fluid, more intracellular fluid later down the line. But so when, again, back in my dark old days when I was just like 5 litres of fluid, 6 litres of fluid, keep going, because it keeps them away from ITU, and I must be a hero and I must stop everyone from coming to ITU. Yes, those dark old days existed. And like patients were getting 6, 7 litres of fluid in the ward. Like there is actually, like, what is it? There is an upper limit. Your sort of like blood volume. What is fluid? What is the limit? I mean, your blood volume is what, 70 mils per kilo. So for a 70-kilo man, 70 times
4.9.
Thank you. So actually, if you replace their entire intravascular volume with normal saline, you should probably stop. You should probably do something else. So dark old days, Joe. No, that was bad. You should have admitted them. Been there, done that. Still doing it sometimes. DKA HSS, the pathology is osmotic diuresis. So actually you can give them 5, 6 litres of fluid, because they will just pee it out and they will keep peeing it out. They can have 5, 6 litres of fluid and then keep going, obviously as long as they can cope with the fluid loss. Pancreatitis, so same as sepsis, they have that sort of like inflammatory response, endothelial leak, but they've got an additional compartment, which is actually because they're like chewing up their insides. They've got the third space loss. Should probably still stop at 6 or 7 litres, then admit them. Open surgery, and this is where I was talking about surgeons writing paper. So surgeons have done lots of studies where they like wrap some cling film over an open abdomen and then they like measure the amount of fluid that evaporates from the abdomen. I know it's ridiculous. And like ridiculous numbers come up, which is like 1 ml per kilo per hour in an open abdomen. So for a 70-kilo man, that's like 70 mils an hour.
Yeah. Yeah.
So like the surgeons are like, don't give my patient too many fluids because then their anastomosis will break down and it's all your fault. Look, they only lose 70 mils an hour. And it's just like, yeah, but they have like organs to fuse. Shut up. So that is the problem with surgeons. Like they have their anastomosis and then they've done an experiment by wrapping clean film over an abdomen and saying, don't give my patient fluids. And we're like, yeah, but AKI, look at our studies. Conflicts between surgeons and people who do medicine. Sorry. And then underneath the bottom bit, it says hemorrhage is hemorrhage. If they're losing blood, give blood. There is no such thing as too much blood if they're like that. So that's the history. Examination. This is what we do a lot of on ward rounds. We stare at the big chart. Observations, high blood pressure, low blood pressure. I'm not going to teach grandmas to suck eggs. We do a lot of chest listening. If they're on 60% oxygen, we're like, oh, they were overloaded. And if they're on 21% oxygen, we're like, it's all right, we'll leave them boggy, it's all right. Peripheral edema, but also think about what's happening in the other organs. If they're on 21% oxygen, but they're really boggy and they've got a bit of ileus, have they got like boggy gut as well? Urine output. So I'll put here, beware the intubated patient. Intubated and post-operative patients, part of the stress response is to chuck out a load of ADH, which stops you peeing. I've been remembering that since year 11 biology. ADH stops you peeing. So you're sort of like post-operative patient, which is only chucking out 30, 40 mils of fluid an hour, doesn't necessarily mean that they're behind. It's just their stress response is working. And I don't know if you've seen, like I've seen a fair amount of patients that you extubate them and then suddenly they dump everything out and you're like, oops. Fluid balance, we definitely should look more at that, sort of like, if they're 2 litres, 3 litres positive day after day, then that's definitely, like they could like gain 7 kilos. It should come off. And underneath there it says passive leg raise / tip the bed. We've all done that as an examination of whether they're fluid responsive or not. Another thing that we look at, this is more aimed at Simon and Kieran. If you have seen us all sort of like hovering near next to the arterial, like, really intelligent, this is what we're looking at. So the arterial waveform goes up and then there's a little notch, and the little notch is basically so the first upstroke is ventricles going through and then blood pressure goes up. The second little notch is the arterial pressure going up and closing the aortic valve, and when the aortic valve closes then the blood pressure goes a little bit. I don't feel like this is live, by the way. That's how I've made it this far in my career. I have another way of talking about this, but does that make sense? Yeah. So that's the arterial waveform.
So it doesn't look like that's okay.
Yeah, basically. So from the arterial waveform, we can, in my simple little brain, gather 2 chunks of information about someone's fluid status. Number 1 is what the textbook calls cardiorespiratory interactions, which is basically your lung filling affects your heart filling. Now, if you're dry or your heart is empty, then the impact of your lung filling affects your heart filling more. So actually, if you have a look at your variation in cardiac output with breathing, it gives you an indication of how full your heart is. Does that make sense? I will come on to that in more detail. And then the second, and that leads on to, and then the machine chucks out these numbers and they call it stroke volume variation, pressure variation, blah, blah, blah. Why have I put this in a weird order? Right, let's talk about that first. So, like I said, if you have an empty heart, you take a deep breath in, your chest only has so much space. Right? So if you take a deep breath in, your lungs are filling, your heart gets squished. So the next time your heart beats, your blood pressure is lower because your heart is empty when it beats, so the blood pressure is lower. If you are nice and full, you're not dry at all, regardless of how hard you breathe, your heart will produce the same cardiac output. So if someone is dry, their blood pressure will change every time they breathe. So if you've not seen someone do it already, or if you've not, have you ever heard someone say, oh, there's a swing? Yeah, that's what we mean. Have you heard that term? You will hear that term. Go and look for someone that's dry. There's a swing on their arm. There's a swing on their arm. So what you can do, so you know the traces on this. You can change the speed. So at the moment, I don't know how many beats. It might be like 10 seconds per screen. You can change it so that's there's 30 seconds per screen, and what that does is that it really squishes it up, and what you get is the second is this picture on the left. So your art line does this with the ventilator, and that tells you that your patient is dry and can give them more fluid. And if you give them more fluid, then their heart will fill the same amount regardless of how much they're breathing. And then, oh look, there's not a swing on the outline anymore. Caveat, if you have AF, it doesn't work. Because if you have AF, then like by definition, every ventricular beat is different. So you can only use this if your patient is the sounds for it. Next time someone says, oh, there's a swing on the outline, will it make more sense?
Yeah.
Dichrotic notch, we use this a little bit less. So like I said, the dichrotic notch itself is the pressure in the aorta being high enough to close the aortic valve, and therefore it going like that. So if your vascular compliance is low because of sepsis, and basically your aorta is flabby, then it will take longer for the aorta to have a high enough pressure to cause that dichrotic notch. So the more delayed your dichrotic is, you can argue, then you've got your vasoplegic. So this is more of a, if your dichrotic notch is like miles away from your ventricular upstroke thing, then actually you should probably give NORAD instead of giving fluids. Makes sense? And these, so this diagram where the dichrotic notch is all the way down here, and then apparently this is what the article says, oh, we gave some noradrenaline and then it came up, and then we stopped the noradrenaline and then it went back down again.
That's why you see a lot in like NORAD, like those with really high quad strength NORAD, you see that middle a lot.
Yeah, basically.
Yeah.
Sometimes you'll just see what the.
Like, oh, this is not good.
And it's just like, which has harms.
And if they have any aortic valve incompetence, then
That is also a point, then you can't rely on it. Good point. Good shout. Investigations. What have I got here? Ah, yeah. So other investigations. Now we've finished staring at the art line. We finished staring at the obstruct. What else can we stare at? Bloods. You look at your U's and E's, obviously. Your urea is high, you're dry. FBC, if your white cell count is 22 and, no, white cell count is 22 and your HB is 180 and you're about to have a laparotomy, probably need some fluids. That's all that is there for. Base excess and lactate. I think most of us probably worked at Glenfield where we obsess over the base excess. No. When you work at Glenfield, you'll find everyone obsessed, oh, the base excess is -8, must give more fluids. And I never really understood, so I sort of like this everything. And like historically, the reason base excess is used so much to titrate fluid is because once upon a time, we didn't measure lactate very easily, and base excess was the only thing on the blood gas machine that people could use. So if you've got a hypoperfused organ thing, it generates acids, of which lactate is one of them. So more acids is supposed to like represent a hypoperfused organ. So a negative base excess gives more fluids. And then someone invented, oh, let's measure lactate instead, and that became more specific, I guess, because there are many, many reasons why your base excess goes up. This is not an acid-based lecture, so I shall not go into it too much. But basically, base excess and lactate is something else that we use to titrate fluids. But like I said, there are many, many differentials, such as ketones and renal failure and ethylene glycol. What else? And other stuff. So there are many caveats to using base excess and lactate to titrate fluids. Liver failure patients, they were clear.
a lot of poisoning.
Poisoning, all of them. Sorry?
Mud piles.
Mud piles.
That's why I'm trying to recite.
I hate acronyms.
The high. Metabolites.
That would be useful for NRCP.
Chest X-ray, pulmonary edema, offload. Do I need to say anything else? Echo, whether or not you believe it is, you know, the panacea of fluid assessment, I do it. And if I don't like what I see, then I put it away and I don't say anything. And when I like what I see, echo, look what I found. Let's be honest. But there are some different pictures here. There's a dilated LV, stop giving fluids. It's a dilated RV, offload some fluids. What have we got here? We've got a pleural, no, that's a pericardial effusion. And that's a pleural effusion, offload fluid, / find out what's giving the patient massive pleural effusion. And that's an MTIVC. There are many, many caveats to these measures, which I shall not go into, but it exists. Lung ultrasound, that is a pleural effusion, fluid overload. These are B lines. B lines being echogenics, blah, 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 off interstitial fluid, lung, blah, blah, blah. Vexus is sort of like the new up and coming thing. So IBC being sort of like, well, everyone can find the IBC. If it's dilated, you're fluid overloaded. And people are like, but what if you have tricuspid regurg? And what about the other organs? So someone's come up with some sort of like, what's the word, like algorithm / pattern. It was like, how about we look for the hepatic vein and the portal vein and the renal vein and see if they're dilated as well and measure the Doppler. It's all very complicated. I just look at fluid balance and give proof and see what happens. So, any questions? How much sense did that not make?
Why reach plasma air or not?
Cheaper? I don't actually know. Well, I know in theatres, someone made the argument, so Hartmann's has calcium in it. And if you mix blood and calcium, then it clots. So in theatres, I don't know if that's why they changed to plasma light, but ever since they changed to plasma light, it's like, now we can give blood really happily.
Yeah, I know someone mentioned that before.
Yeah, we was explanation.
Sorry?
Like 2 days.
Yeah.
I only know the separate one kind of
In the league.
because it does the same blood.
I thought it's possible.
Is there any, I mean,
Oh,
plasma light is marginally more physiological than Hartmann's as well. Alan, the pH is nicer. And it's less hypotonic. That's all. But I think the difference is probably marginal.
yeah.
Right, recap. Oh, God. What happened? I mean, the recap is basically the plan page. Where is it? I've tried to answer these questions.
I think the hard bit about giving fluid, especially on the wards, is the threat of, they have congestive heart failure or whatever. Suddenly they're on like fluid restriction on like 50 mils a day or something.
That's true.
Just
It explains my
accepting-
second message.
Yeah.
So heart failure can never,
Yes, you can get fluid.
no, they can never say that you can fluid restrict them less than 1 liter. So
Yeah.
normally 1 liter is the maximum fluid restriction they do.
Yeah.
Otherwise 1.5 liters.
Yeah, but you see them on the wards, they're like crispy.
Yeah. It's not just because of fluid restriction. So I myself have prescribed maximum 500 milligram protein, like in an infusion for 12 hours.
Yeah.
So that's a lot. So that
Yeah.
also gives them on top of fluid
Yeah.
restriction. So we need to assess them every day.
Yeah.
So it's 500 furosemide that is making them dehydrated.
Yeah, it's a combination. Like it's the same ED, like they see heart failure and suddenly like they can't, they're allergic to giving fluids.
Yeah.
They're like, oh my god, like, I can't give fluids anymore. What a septic. You know,
Like
Yeah.
that heart transplant patient 2 days ago, like, they're like, blood pressure's like, it's like 80 systolic. I went down, they'd only given 250 mils of blood 8 hours ago, and it's like, you're like, Did you give him a lecture about transplanted heart transplant?
Yeah.
Can't
I give them heart transplant because the heart, well, the thing is, if you transplant the heart already, so it'll work.
As well.
You've gotten rid of the bad heart.
Supposedly.
Supposedly.
Please give me any feedback.
Oh yes. I will give myself feedback.
I will give. I don't
Yourself,
want
you give yourself feedback.
Thank you. I'm sorry I droned on a bit.
No, you didn't. Honestly, it was like,
It was very good.
it was just right.
Yeah.